with immediate access to potential users around the world. Bayer is illuminating the path forward, generating results from a world full of potential. We're excited for the journey ahead. Let's take the next step together. We want to meet you. Schedule a meeting to share what you're developing.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.
Okay. Already now? Can you hear me? Hello?
Hello?
You hear me clearly?
Yes, Professor.
Okay, we start now. Good afternoon, colleagues and friends. We will begin the section of this afternoon. I'm very honored and happy to co-chair with Professor Cho, one of foundation member and VIP of Asci Society. Professor Cho, always with our society, and he had many lectures from the Asci building and Asci Square, Asci Cube. He has been president of Asci. And now, Professor Cho co-chair with me this afternoon. To begin this afternoon, Secretary shall for me for CV of Dr. Chang. The first topic, talk about CM bar sequencing from physics to clinical application. Dr. Chang has been finished the doctorate in Taipei, and now he has in Radiology Center of Bạch Mai Hospital. In this important event, he had the General Secretary of Asci meeting in Vietnam 2021. He has many published, and also he has 2 times Asci Cube, Asci Square the past year. And now he will present the topic CMR sequence from physics to physical application. Dr. Nguyễn Ngọc Tráng, please.
Yes, thank you for your kind of introduction, Mr. Professor Lợi and Professor Ye Hong Cho, Mr. Chairman. So I would like to share my presentations. So for the beginning of this sections about the CMR, so I would like to present the topics about the CMR sequence from physics to clinical applications. I'm Dr. Nguyễn Ngọc Tráng from Bạch Mai Hospital, Vietnam. So can you hear me clearly? So I don't have anything to disclose. So first of all, CMR is a clinical practice for diagnosis and management of the cardiovascular disorders. And as you know, that this is examination, non-invasive and no radiations. And CMR help us to evaluate the morphology, functions, perfusion, and tissue characterizations. Nowadays, the clinical indication of CMR is widened. And in the CMR position papers published last year, we can see here the majorities of the indication for CMR is from class 1 to class 3. For all the fields such as congenital heart disease, cardiomyopathy, pericardial disease, and cardiac mass. So how about the CMR sequences? This is a trend of RF pulsars that are used to produce MR signals and can distinct image contrast. So if we understand the design of the pulsar sequence, that will help us to understand the mechanism and improve the image qualities and have the optimal sequences in clinical practice. Normally, we have the 2 main basic CMR sequence. The first one is the spin echo, and the second one is the gradient echo. So first of all, we go to spin echo first. Normally, with the conventional spin echo, we use a RF pulse sequence. Might train the magnetizations about 90 degrees and follow up with 180 RF pulsars. And then we can have the signal here. But with the conventional spin echo, the acquisition time takes longer. So that's the reason why we need the fast spin echo. That means we can use a series of 180 degree RF pulsar, follow up by a 90 degree RF pulsars. So with that, we can have the more signal here, and then can reduce the acquisition time. And together with the K-space, each signal we can store in the K-space, and then we can have more data and decrease the acquisition time with the fast spin echo. And one important spin echo is the black blood spin echo. And you can see here with the black blood spin echo, we can use another preparation pulsar, or we use a pre-pulsar to suppress the signal from the blood with the double inversion recovery technique. The first one is 180 pulsar to inverse the magnetizations of all tissue and blood. And the second inversion recovery we use to reinverse the magnetizations only within the slide of tissue to be imaged. And besides, we have another technique, a triple IR technique, that we can suppress the fat signal. We can call this dark fat. So how about the applications of this sequence? We can use this to not only characterizations the myocardium, because, and together we can see the cardiac tumor, evaluation about the pericarditis, myocarditis, and even in the ARVC. For example, in this image, you can have a fat band at the RV wall here. And this sequence is low susceptibility to artifact for metabolic biomedical implants. Another case of male patient, 36-year-old in the dark blood, and we can have the non-compaction cardiomyopathies at the RV together with the dilate, very large dilates the RA. So the second basic CMR sequence is the gradient echo. Here we can see that this sequence only uses the weak radiofrequency pulsars. The weak radiofrequency pulsar only changes the magnetization of flip angle about alpha degree, or normally is under 90 degrees, and that have the second can be acquisition faster than spin echo. And the major technique we use is the balanced steady state pre-perception, BSSFP. This is a rapid gradient echo sequence with phase shifts induced by the image gradients exactly 0 at the time of the TR, so that we can have the high signal intensity and high tissue contrast between the blood and the myocardium. And normally we take the image at the retrospective ECG gating. With this technique and together with the case space, we take the picture at the multiple phase together, and then we can have the combine the picture together to have the cine imaging. For example, in here we can see in the 2-chamber view, 4-chamber view, and short assay view. In this sequence, the blood is become bright. So with the dynamic image like this, we can access the functions or can see the local world motion. Coming up next, Dr. Huynh Wu will have the presentation about the LV function. So I just have some short slide about the LV functions in the cine imaging. Here we can see normally in CMR, the LV function measurement, normally we can say this is a kind of standard reference in comparison with other image modality. And besides the LV function, for example, ejection fractions, we can have the other analysis, such as the strength, the LV mass, or the wound thickness. In this image, we can see the LV strength in this sequence. We can have the calculate the radial strength, the circumferential strength, or the longitudinal strength. And also with the gradient echo sequence, we can analyze the wound thickness. Here in the 47 female patients, we can have the hypertrophy cardiomyopathy here, and then we can have the wound thickness mapping very clearly. RV function also very useful with the CMR, but I just skip this slide when we have the next presentations. Normally we can use in the CHD for tetralogy of failure, TGA or ARVD. And other thing, we can use the application with the bright blood gradient echo sequence with the 2-chamber, 4-chamber, and we can have analyze the valvular insufficiencies, outflow tract obstruction, ventricular wall motion, or even mobilities of the cardiac tubes. So the next part, we can talk about the tissue characterizations. For this technique, we have a major 4 kind of technologies. First of all is the perfusion, late gadolinium enhancement, and then T1 mapping and T2 mapping. For the perfusion, normally we use P-pulsars, inversion or saturation pulsar, and follow up with the multiple T1 dependent to take the image of the first part of the gadolinium to the myocardium. And the second normally we use is fast point gradient echo sequence. And the perfusion we can use in the rest or stress perfusion. In this case, we use the stress perfusion here. We can use the stress perfusion with dobutamine, adenosine, or regadenoson. Or this is the 2 kind of dilatation agents. And with the perfusion, we can do the preparation sequence, then bolus injection, And then we can have the RV enhancement here, and then follow up with the LV enhancement. And after that, we can have the image of the myocardium enhanced. And then we can have clearly the defect of perfusion here at the anterior septal wall in the stress perfusion. And besides, right now, we can do the quantifications of the myocardial perfusion and make a flow map for this. We have another case. This is a patient we have, and when we do the perfusions and the left gadolinium together, we can make differentiations between the myxoma and thrombosis. For left gadolinium enhancement, I just show a short slide because later Professor will have a presentation about the LGE. But normally we use this to take this sequence. This is a T1 sequence. Normally at the 10 or 15 minutes post gadolinium, and normally we can have a two kind of sequence is flash or PSIR with high image quality and high spatial resolutions. And in this one, now we can improve the breathhold limitations even with the free breathing or single shot imaging also. Here we can use this sequence to check for the viabilities, and normally infarction's myocardium is white, and this patient is the main patient 72 years old, and we have the total occlusion at the conventional coronary angiography here, and has transmural infarctions become bright in the PSIR image. Besides with the ischemic heart disease, the LGE can help us to make differentiations with the non-ischemic heart disease. This is the kind of focal LGE, late gadolinium enhancement, in the cardiac sarcoidosis. And another interesting case is a mass we can see here, high signal on steer, and in perfusion here, the mass here enhanced strongly together with the aorta, and the LGEs, we can have the mass enhanced homogeneity. It is the RV hemangioma, and we can make differentiation together with the thrombosis also. Coming up next is T1 mapping. So as we know that the focal fibrosis can be detected by the LGE, but how about the diffuse or interstitial fibrosis? So in 1970, Luke Locker already found this sequence. It is a 180-degree inversion punch and come together with a series of single shot T1 weighted images. And then we have the modified MOLI, and the original modified original MOLI sequence they acquired with 11 inversion recovery image over 17 heartbeat, and it takes a long time for especially in patients cannot have good breathhold. This is a diagram of the original MOLI, and we can take the protocol the 3-3-5 follow up with the recovery periods, and then we can mix all the image of T1 mapping together. We have a T1 map. And besides, we have some variants of T1 mappings. For example, it is short MOLI that can reduce the scan time, or we can have a saturation recovery single shot acquisition SHA. This is MOLI with saturation recovery, and this one is less sensitive to heart rate variations and have high accuracies but lower precisions. How about the application of T1 mapping? As we know that T1 mapping have multiple roles and now become more and more the conventional sequence for the tissue characterizations in clinical practice. Therefore, the myocardium will increase the native T1, can show the edema, in inflammation or myocarditis or acute myoinfarction, or increase interstitial space in the non-ischemic cardiomyopathy, for example, HCM, DCM, or amyloidosis. In case we have a low T1 values, we can have in Addison Fabry or lipomatous metaplasia with lipid overload, or even in iron overload that can decrease the native T1. And sometimes it's very helpful with the use of the native T1. That's going to make us the differentiation between the amyloidosis or Anderson Fabry, or even with the HCM patient. Here we can see that with the hypertrophic cardiomyopathy or dilate cardiomyopathy, with the native T1 mapping, and even with the ECV, we can have the analyze the fibrosis in the myocardium. Even in the LG, we could not see the late cardiac enhancement focal fibrosis. This is the ECV we can use to calculate pre and post contrast together. For T2 mapping, we use the spin or check the transverse relaxation time. And this mapping is robust than conventional T2 weighted. And this sequence is very helpful to detect the edema. In case the longer T2 relaxation time, the longer we have the increase the water content, and we can find out the myocardial edema. Normally we have two types of T2 mapping. We can have a dark blood or bright blood T2 mapping. For example, here we can have the multiple T2 images together with the TI recovery, and then we can mix together to have the mapping, T2 mapping, and then we can calculate the value also. But sometimes T2 mapping have a limitation, like ghosting artifact that can cause a right subendocardial rims or through plane motion that can cause the signal loss. So with that, I think my presentation have a short point of view to understanding the CMR physics sequence is helpful for analyze and optimal image quality. And from the basics and advanced sequences, it play an important role in the clinical practice, clinical application for CMR. With that, I would like to thank you for your kind attention. Yes.
Thank you, Dr. Chang. Thank you, Dr. Chang. I will appreciate the topic and important for the beginning MRI practice. And we do with many sequences and with many sequences for evaluate personal. Thank you, Dr. Chang. We will return after finish our topic. And the second topic is the topic functional analysis, LV and RV, presented by Professor Huynh Wu Yo. He worked at University of Ulster College of Medicine, Seoul, Korea, and he has been many articles for coronary angiogram with Kawasaki disease, and many emphasis on image sharpness for cadicity between all data. Now, Professor Huynh Wu will present the topic functional analysis, LV and RV. Please, Dr. Wu.
Thank you, Chairperson, for your kind introduction. Also, thank the organizing committee for inviting me. I'm pleased to have this valuable opportunity to present my clinical experience on this special occasion of Asci 2021. As introduced, today I'll give you a talk about the assessment of ventricular function using MRI. In my presentation, I'll talk about how I analyze global function in my practice, including data acquisition and data segmentation using different approaches and different degrees of user interaction. Subsequently, I'll briefly mention various techniques used for regional function analysis. As many of you know, the assessment of ventricular function is important because it provides a crucial measure for risk assessment, treatment planning, and prediction of clinical outcome in various congenital or acquired cardiovascular disease, pulmonary vascular disease, and metabolic syndrome. We can evaluate whether changes in the measures are adaptive or maladaptive as a consequence of ventricular remodeling after treatments. For the assessment, we may use 3 imaging modalities, including echocardiography, cardiac MRI, and cardiac CT. As you know, CMR is commonly regarded as a reference standard for the assessment of ventricular function. Echocardiography often can't provide adequate visualization, particularly for the RV, which clearly limits its clinical use in spite of using 3D echocardiography. In addition, 3D echocardiography tends to underestimate the RV volumes, approximately by 7% compared to CMR result. In contrast, cardiac CT tends to overestimate the RV volumes. The limits of agreement were similar for both cardiac CT and 3D echocardiography when CMR values were used as reference. On the other hand, cardiac CT showed highest reproducibility among them. As expected, inter-observer variability tends to be greater than intra-observer variability, as you see on this table. For the assessment of global function, 2D balanced SSFP imaging is most commonly used. We may use short axis or axial plane for this 2D cine acquisition. The slice thickness is usually 5 to 10 millimeter, depending on patient size, with or without gap. Typically, 20 to 30 cardiac phases were acquired, and cardiac phases demonstrating the smallest and largest ventricular sizes are regarded as the end-systolic and end-diastolic phases, respectively. Some people use 3D whole heart SSFP imaging for the global function assessment. On this occasion, 3D data is usually acquired in the axial plane and only at the 2 predefined cardiac phases, which are theoretically the end-systolic and end-diastolic phases. This slide shows 2D cine images acquired in axial and short axis planes, and the volumetric result of the LV and RV cavities segmented using 2D simplified contouring and disc summation method. Respiratory misregistration artifacts in 2D acquisition frequently lead to inaccurate results, especially in dyspneic or young patients. Short and single acquisition with low spatial resolution or high acceleration may be helpful to cover the entire ventricles and therefore reduce the artifacts. The potential benefit of 3D acquisition for ventricular volumetry was previously demonstrated using an RV-shaped plastic phantom. As you see on this table, only 0.7% error took place in 3D volumetric analysis, while 2D disc summation produced 20% errors. As a result, 3D volumetric analysis can improve accuracy and reproducibility of the results of ventricular volumetry. The same German group have reported 3 articles demonstrating usefulness of navigator-gated dual-phase whole heart SSFP imaging for ventricular volumetry. So I compared this 3D imaging sequence with conventional 2D cine imaging a few years ago to test whether their results are really true. Notably, I found that this 3D navigator-gated whole heart imaging sequence should not be used for ventricular volumetry because the end diastolic phase achieved with this sequence is not truly end diastolic phase, and the longest delay of the sequence is insufficiently short to reach the true end diastolic phase, which result in a substantially smaller end diastolic volumes. Okay, let's move to segmentation and user interaction for global function analysis. Manual or semi-automatic simplified contouring and disc summation using 2D short-axis cine MRI is widely used, despite of its limited accuracy and moderate reproducibility. Rule of thumb used in the method is as follows. Number 1, contour compacted contour endocardial border as simply as possible by including papillary muscles and trabeculations in the ventricular cavity. Rule number 2, the basal section is regarded as the ventricular cavity when the cavity greater than 50% is surrounded by ventricular myocardium. Other source of errors in the simplified contouring and disc summation includes incorrect valve planes and moderate reproducibility. Moderate reproducibility may be improved by training the observers, and segmentation of valve planes may be improved by cross-reference may be improved by using cross-reference images as you see on your right. Segmentation approach is largely divided into simplified contouring, detailed contouring, and threshold-based contouring. The papillary muscles and trabeculation should be included in the myocardium rather than in the ventricular cavity because their volume is responsible for 23% of LV-EDV and 21% of the RV-ESCV according to the studies. Various global function measures can be used, including end-systolic and end-diastolic volumes, ejection fraction, stroke volume difference between the LV and the RV, RV to LV volume ratio, myocardial mass, and mass to volume ratio. Ventricular remodeling can be evaluated using this global function measure, particularly the mass to volume ratio. Boston group reported that hypertensive response to exercise was associated with increased LV mass to volume ratio even after adjusting for multiple covariates in patients with repaired coarctation of the aorta. They also recently found that similarly, RV mass to volume ratio is a better prognostic factor than RV volume itself in patients with repaired tetralogy follow. I also demonstrated that LV remodeling pattern using mass and mass to volume ratio may be used to predict clinical course in patients with a left heart obstructive lesion using 3D CT data and 3D threshold-based approach, as you see on this table and these figures. As far as I know, there are a couple of companies actively developing artificial intelligence-based automatic software for ventricular volumetry. A few are using 3D threshold-based segmentation and partial voxel interpolation technique to achieve extremely accurate results. I hope I can use one of them in my clinical practice in the near future. Lastly, I'd like to briefly mention regional function. The most significant finding of regional function analysis is that it can detect subtle abnormality in the subclinical state of diseases. As regional function measures strain, strain rate, rotation, torsion, and dysynchrony may be used. It should be noted that all the measures are unfortunately affected by loading conditions. Various techniques may be used to evaluate regional function as listed on this slide. Tissue tagging, phase velocity mapping, displacement encoding with stimulated echoes, strain encoding, and feature tracking. Tissue tagging is a visually appealing method, but needs time-consuming post-processing. It's the most widely accepted technique and has a tag fading issue. Phase velocity mapping is widely available with quick post-processing time. However, the technique is prone to motion artifact and phase distortion. DANCE is simple and quick post-processing time, but limited by low SNR. The technique is not widely applied yet and has a tag fading issue. SANC imaging can demonstrate through-plane strain from pixel intensity, and therefore additional processing is minimal. Scan time is so fast and therefore almost real time. But the technique has a fading issue as seen in tissue tagging and dance. Feature tracking is a recently developed technique that is comparable to speckle tracking, and therefore strain values can be calculated by tracking epicardial or endocardial borders. The most pronounced advantage of this technique is that we can use conventional CineMRI for this technique, and therefore we don't need additional imaging sequence. To conclude, in this presentation, I demonstrated that CMR can be used to evaluate global and regional LV and RV function. Data acquisition and post-processing still needs to be faster and more reliable. Higher reproducibility and smaller inter-reader or inter-study variabilities are required to identify small differences between serial intra-individual follow-up studies. With that, I hope you enjoyed my talk, and thank you very much for your kind attention.
Today, Professor will comment and present my topic. Please, Professor.
Thank you, Dr. Gu, for your very comprehensive lecture. It's very informative. Last speaker is Dr. Hwang Min Roy. Actually, the lecture by Dr. Zhao Shua was scheduled, but it was canceled because of personal reason. So Dr. Hwang Min Roy will present late gadolinium enhanced MRI and cardiomyopathy. Dr. Roy is our EC member since our society establishment. He is the vice president of Vietnam Society of Radiology since 2010. So he's one of the very good friend of Asci, and we are very happy for his team for this opportunity of holding a conference here in Vietnam. Dr. Roy, please.
Thank you, Professor. The kind introduction for me. First of all, I would like to say the gadolinium enhancement is very important and beginning use for the technique for CMR a long time ago. But many changes just now with the COVID-19 pandemic that I will represent to show rep and the main principle for the late gadolinium enhancement. And now my video, please.
Good morning, ladies and gentlemen, dear colleagues and friends. I present my topic for late gadolinium enhancement and myocardiopathy. We have 4 parts: basic, physiological, clinical, and take-home one. The first, basic CMR techniques. Black blood for second for evaluate anatomy with spin echo imaging. Principle gas slow-moving structure. Same myocardium, blood pressure, etc. appear bright. And provide high contrast between blood and tissue, such as good for anatomy imaging. And bright blood for flow and anything concern gradient echo imaging, which inflowing blood fully magnetizes appear bright imaging, and gradient echo sequence are very fast. That's why many artifacts of field inhomogeneity and myocardium and other structure appear gray compared to blood. If the turbulent blood flow can cause rephasing and thus give qualitative estimate stenotic for regulation lesion, and recently research present for the 4D flow MRI provide detail of assessment. And the last, sequencing balanced steady state free recession depend the camera Fiesta, Rufus, or EFFE. Onward use of loud flip angle with gradient echo per second. Signal achieve a steady state has both T1 and T2 rating and recall balances. With high contrast between blood and wall of myocardium And the principle of late gadolinium enhancement, we can procedure of technique image capture which 10 to 20 minutes after administration gadolinium using the second inversion recovery, and gadolinium redistribute into interstitial space before renal clearance. And disease processes that increase extracellular problem, focal infiltrative disease, fibrosis, and scar will result and increase accumulate gadolinium that can be imaged and qualified. For example, here gadolinium enhancement with Y in the interventricular septum. That's in fact. And the physiological basis of LG and contrast development, the normal microorganism do not accumulate GBCA. That's in wash out. We can see enhancement, and abnormal microorganism accumulate the GBCA caused by the drumstick membrane cell and expanded in interstitial space. That we should recognize depend distribution and arrangement pattern. And here the normal gadolinium extracellular and abnormal the membrane lesion, he can see disrupts membrane cell, and finally for LG we can see the expand gadolinium extracellular here. That's a mechanism. And depend the LG pattern, LG location, we have about 10 disease, and more common that's myocardial ischemia and non-ischemia, and another myocarditis, etc. And the pattern of late gadolinium enhancement, we have two kinds clearly for ischemic, non-ischemic, which the character by the subendocardial infarct or tremoral artifact in ischemic, and another for non-ischemic, the mid-wall enhancement here for the HCM sarcoidosis, and for the peripheral epicardial global enhancement, you can see in sarcoidosis or amyloidosis or systemic sclerosis. And for the location to define the lesion, we have segment of ASA classification, which 17 segments. The first problem, the clinical application, the preparation for CMR of LGE, many parameters to have good imaging, but always important, we should do with examination for GFR to avoid NSF in patients with low GFR. But we have many advantages: non-invasive, no ionizing radiation, useful for serial follow-up study of pediatric population, no radioactive isotope or iodinated contrast, high spatial and temporal resolution, increase the number of indicates for use, and many research, but CE mark study prospective trial have evaluated very good sensitivity with 86%, specificity 83, etc. And how to interpretation and reporting. We have to inform, to recognize how to different uptake, what our race, depend the type of tissue, subendocardial, wall, myo, pericardial, pattern enhancement, and local for a 17 segment. And finally, the white, black, or gray. That's important to recognize. And the sequence to recognize, first of all, T1 mapping with dry blood, we see co-look locker, and T1 mapping with LENG, T1 PSIR, phase sensitive inversion recovery, T2 IR, tablet LG, double LG, deploy at inversion recovery for detection of scan. And we have some case, first of all, for ischemic pattern, that the shimmer of this image in the patient with MRI contrast injection, LG, action COT1, and this patient have acute infection suggestion on the clinical and ECG 3 days ago with a large anteroseptal infection, necrotic myocardium wide microvascular lesion of subendocardial here, black. Ischemic pattern for LAD lesion, that's the segment of the anterior here with the black and white here, similar with the ischemic pattern. And the same RCA for the location here and here. We can define which a HA segmentation. For the ischemic pattern, compare with another method. For the SPEC series, we have here, the lesion here, and MRI here for the left ventricle ischemic. But many research, the wonder it all of the Lancet journal since 2003 demonstration MRI not higher value the same spec city, but in about 2010, just now 2020, we have PIT MR right here and PIT MR here and MR only with the LCE. You can see the similarly, in fact, about 22% of total left ventricle in volume the same, and about 20 that we have increased evaluate exactly for the MR with LG. And for the non-ischemic pattern, diagnosis and prognosis, here ischemic and non-ischemic, we can see the middle wall and the subendocardial wall. Many research since 2013, and now we can use many sequences. For example, here T1 gated post contrast, you can see here that clearly, but for the delay enhancement, you can see here. And the last, which persevere, very sensitive inversion recovery. You can see clearly here non-ischemic of myocarditis. And for the sarcoidosis, but the location very important, but interventricular, left ventricular, etc. We can see with LCE here, interventricular here. That's the pathologic for cardiac sarcoidosis. And the late sequencing for demonstration clearly many perspective comparison of novel DAC blood LGE to detection of scar. Here we can see DAC blood with the novel. We can see clearly here. Compare here. That's very useful to evaluate scar. And another inflammation, pericarditis, we can see clearly for the pericard here and here. And if we have constrictive pericarditis, we can see the septal shift here. And nowadays, for the COVID-19 pandemic, we can know totally about principle. The COVID-19 will attack with myocardium and cause many lesions, and two kind, acute and chronic. Acute, the cardiomyocyte injury or myocardiovascular damage by the release secondary inflammation cytokine IL-6. And many reports on the journal in 2020 May to recognize COVID-19 related myocarditis. Here with the symbol many delayed enhancement of the myocardium with the typical AC, that the cardiac edema, and B and D. LGE pericardial and the ventricular. That's the scene of myocardial fibrosis or scarring. That's very important to evaluate the patient now. And checklist for assess pattern LGE, ischemic or non-ischemic, easy to different. With ischemic LGE, subendocardial enhancement with coronary artery perfusion territory, and non-ischemic not kept spare subendocardial mid-wall epicate of the transmural withdrawal cap territory, and location depend a 17 segment. And arranges average transmural extent of LG each segment from 1 to 3 degrees by 1/4 part, from 0 to 25, 36 to 50, 51 to 75, 76 to 7%. And we have evaluate for viability, recovery of hypokinesis. When there is the past myocardial infection scar with cap, about 50% scar, that means significant viability. And 51 to 75% scar, low ability of functional recovery, and the upper 76 scar, no viability. and very important to recommend the PCI. Finally, key point, we have LG useful for distinguish between ischemic and non-ischemic cardiomyopathy. Specific LG pattern are seen in non-ischemic cardiomyopathy. LG also is simple, robust, well-validated method for assessment of scar in acute and chronic myocardial infarction. Patient study using T1 mapping have varied study design and acquisition sequence. And despite of different technique, clearly pattern and has been seen in death in cardiac disease support contract, T1 time are shorter. And extracellular volume measure, which cardio series represent a new approach toward clinical assessment to diffuse myocardial fibrosis by evaluating distribution of RNA contrast. Thank you for your attention.
Thank you, Dr. Hwang Bin Roy, for your very informative lecture. So the topics are now open for discussion. Please give us comment or questions.
Okay. Now we have not the question on the screen, but I have the comment for the topic of functional analysis, LV and RV, of Dr. Gu, because just now, CMR always comparative with echocardiography, because recent year ago, many techniques on CMR, we have attained many parameters. Only before echocardiography can be done. For example, functional EF, flow 3D, velocity, etc. And now we have done the same and almost for the functional evaluate for the cardiac. That's why CMR always many advantage, and anything we have advance in the future. And in Department of Professor Wu, you have done with Flow 3D and application. Dr. Wu?
Which kind of technique?
Yeah,
did you mention?
3D, Flow 3D to evaluate the stenosis or congenital heart disease. You hear me?
Pardon, did you mention 3D technique? I'm sorry. You mentioned echocardiographic evaluation and then MRI techniques, and your question is about 3D MRI technique. Is it correct?
Okay, 3D MRI technique and flow.
3D, flow MRI.
Flow MRI 3D to evaluate when we have a congenital heart disease or stenosis or regurgitation, mitral valve, etc. You had to be there, your department?
Unfortunately, 4D flow MRI takes too long, particularly for pediatric patients. And we need a very good post-processing software, and other researchers usually use special contrast agent or special with special per sequence, the so-called magic, and then we can get a nice image quality in 3D and with flow information. However, I think for the flow imaging, we have to improve the scan time and the processing software to use in our clinical practice. Thank you.
Okay, thank you. And how about your idea, Professor Chue?
I want to ask Dr. Gu. Dr. Gu?
Yes.
So, do you frequently use CT, cardiac CT, for evaluation of right ventricle function in a congenital heart disease patient?
Yes.
Compared with the MRI, yeah.
Yes. So the number of cardiac MRI for evaluating congenital heart disease is dramatically reduced. So, for example, one case per week or nothing. And the number of cardiac CT exams is extremely high nowadays.
Then, how would you choose the technique for functional assessment in small children? So, for the functional analysis, you need full coverage or limited coverage of a full radiation dose. So then it may risk the radiation hazard. So how can you optimize in selection of patient?
Actually, we try to reduce radiation dose, and now is quite low because we can focus on the endosystolic and the diastolic phases rather than covering all cardiac cycle. So I think that the clinician just asked me that the level of radiation dose, and I said that compared to others, the CT protocol that I use can reduce the CT radiation dose. For example, for young patients, the radiation dose estimate is approximately just 1 millisievert or lower. So I think is reasonably low. And another thing is that I've recently found is that actually the serial changes in ventricular volumes is very small than as we previously expected. So the European guideline recommended 2 to 3 years, every 2 to 3 years to evaluate congenital heart patients after surgical repair. However, we need to modify the guideline. So, for example, we should extend the time interval. For example, more than 5 years. In this regard, we may use CT with less accumulated CT dose. That's a good news. Every 2 to 3 years.
Okay, thank you.
Thank you.
I want to ask Dr. Zhang and Dr. Roy, how is the status of cardiac MRI in Vietnam? How many cases are you doing regarding cardiac MR? And I just want to know the MR cases is increasing in your department?
Okay, Dr. Chang, first.
Yes, thank you, Professor Chue, for your questions. Actually, for the CMR in Vietnam, we start a little bit late in comparison with other Asian countries. I remember the first case in the north of Vietnam in the year 2008, and maybe in the south a few years before. And at that time, when we beginning with the CMR, the acquisition time is take very long, normally 1 hour. So the number of cases at that time is very rare, just a few cases per month. But until now, the number of cases already increased, especially in the big cities like Hanoi or Ho Chi Minh City, or in Central Hue or Da Nang also. Because right now we have the new modalities, 1.5 Tesla or 3T, and the indication right now from our colleagues cardiologists increase also, and we have a high demand. So, for example, in my hospital right now, we have around maybe we can have about 7 cases or 10 cases per week. But as you know, our machine is very busy, so we just arrange like this, just 1 or 2 cases per day. We cannot increase the number of cases. Yes.
Very good.
Please, yes.
Okay. In my knowledge, because for the lay development in Vietnamese physician, and problem is facility, machine, and also indication from the clinical physician. Combined with clinical and radiological, not correspondent, because indication for CMR very few, except for the heart institute in Ho Chi Minh City and Hanoi. But the first hospital in Vietnam use CMR, and now we have developed gradually. And we have not many experience in the Asci team, Asci VIP, etc. That's why we will present the basic fundamentals to knowledge for many students and the physicians to know. By Asci this time, we will have communication very important, how to do, how to indication, and what effectively. Finally, with me, when I were in Vinmec City, in big city of Vinmec in Hanoi, we do some case, but not total in evaluate for the viability, etc. And now we have a start in Hue, because now with the sequencing or any software of machine not adapted for any sequence for all renal for the evaluation for the cardiomyopathy. But we will try to have a little bit. Thank you, Dr. Xue.
I think the Asci Congress may give young radiologists good opportunity for learning. Yeah.
And now we have. Thank you for presentation.
Is there any other questions?
Because now. Maybe can I have a small question for Professor Wu?
Dr. Gu?
Yes, please.
Yes. So actually, right now when we do the CMR for the RV and LV functions, do you think the AI right now can train the workflow for us when we do the LV and RV analysis, even in the adult and in the children? And in your experience, do you use AI for analysis in your hospital? Thank you.
Your question is when we use cardiac MRI for ventricular function analysis.
Yes, and then do you use AI, the machine learning for this?
Machine learning?
Yes.
That I think is not available yet for commercially available software.
Yes, because before I think we have a little bit time consuming to do the LV and RV analytics. So maybe you think in the future if we have the like AI software that can skip the time, reduce the time for analytics.
Yes, definitely. In the near future, we can reduce post-processing time.
Yes.
It's good for us. Thank you.
Thank you.
Thank you.
Thank you.
Thank you very much. Yeah. Thank you very much for your participation, and thank you, speakers, for your very excellent lectures. So we want to conclude this session. Thank you very much. Good evening.
Thank you. Good evening. Bye bye.
Bye bye.
with immediate access to potential users around the world. Bayer is illuminating the path forward, generating results from a world full of potential. We're excited for the journey ahead. Let's take the next step together. We want to meet you. Schedule a meeting to share what you're developing.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.